We ready to begin?
I don't know. I'm waiting on the thumbs up from Stephanie.
Okay.
We're good. All right. We will call to order the meeting of the Shawnee County Board of Health. I am Commissioner Mays, representing District 3. On my left is Commissioner Rippon, representing District 1. And Commissioner Cook is on Zoom, representing District 2. First item, please.
All right. I'll introduce. Good morning, Commissioners, and welcome to today's Board of Health meeting. For those of you who may not know me, I am Teresa Fisher. I'm the Director of the Shawnee County Health Department, and I'm also currently serving as the Incident Commander for the COVID-19 response team. I would like to welcome everyone who is in attendance today, both of those of you in person and also those attending virtually, including a special welcome to our presenters today. Most of us, including myself, likely never thought we would be where we are today, standing here on January 10th, 2022, still dealing with a worldwide pandemic that started nearly two years ago. I hope that everyone will find today's meeting informative and insightful as we discuss the current state of our community. Today's agenda will feature presentations and updates from several key stakeholders in our community's response to the COVID-19 pandemic. Each of them will be giving updates as it relates to their area of expertise. Now I would like to introduce our first presenter of the day, our Shawnee County Health Officer, Dr. Erin Locke. She will start us off with a comprehensive overview of the current COVID-19 situation and its impacts on our community.
So just to kind of clarify, on the agenda, these are all listed as individual items, these presentations. And so I'll just go ahead and we'll just work in order, okay, without introducing each individual agenda item, if that's all right with the two of you.
Yeah.
Okay.
That works.
Thank you.
Okay.
Good morning.
Morning.
My name is Dr. Erin Locke. I'm the Shawnee County Health Officer, and before you today to give you an update on the situation of COVID-19 in Shawnee County. I'm going to try to be brief on this update. And okay, so to start with, our indicator. This is not a new indicator. This was published last Wednesday, and as you can see, it was high. In particular, and incredibly notable, was the week-to-week jump in cases. We had 750 cases and then nearly 1,500, so it essentially doubled from one week to the next. We also experienced quite a jump in our testing percent positivity, up to almost 20%, which was, again, a significant change. Despite the fact that we were actually testing at higher levels, we still had a high percent positivity. Just to put this into perspective, this is from June of last year to the present, our weekly cases, and you can see the most recent and just how much higher it is, even in the peak of the Delta wave. And for further perspective, going back even another year to September 2020, you can see how much higher this last week was than before. The data for this coming indicator is still preliminary, but we do believe that it will be even higher yet again. When we look at testing, our percent positivity remains far above our goal of less than 5%. And I put that as a bold line there so that you can see we'd like to be below the bold line, but as we are headed in the wrong direction. Right now, 1 out of every 5 individuals in Shawnee County who tests is positive for COVID-19. We would like it to be 1 in every 20. So we are very far from our goal. Just to put that into perspective again, this is going way back to September of 2020, before our winter wave, that first winter wave. We really only were as high as we are now the one time when we were sort of in the worst of it. So as I mentioned before, we are actually testing at higher levels, nearly 7,000 tests per week. The problem is that there is just so much demand that availability is limited. And I suspect most of us have heard a story or experienced this ourselves when we're looking for a test and unable to find one. The incident command team and the health department are actively exploring opportunities to expand. We have purchased some tests where we have some plans in place, working with some partners. So our hopes are that in the next few weeks, we will have even more options. But as it is, we do have 2 mass testing sites. One is located at Hummer Sports Park, the other at Walmart on California Avenue. We have multiple pharmacies, our healthcare providers, even some lab providers who are offering tests. And then we have some of our congregate settings, like our schools, our long-term care facilities, our jail, our shelter. They are all testing individuals within their settings. Finally, over-the-counter tests are available, I should say, should be available in stores and online, supply permitting. What I would recommend, I'm so sorry. What I would recommend when you are looking for a test is that you start with the KnowBeforeYouGoKansas.com website. This is just a picture of the map. It shows various locations for testing throughout the city. I'm only going to touch very briefly on hospitalizations because we do have some of our hospital partners who will be presenting today. This data is from KDHE, and it is the hospitalizations for adults that we have experienced in Northeast Kansas, of which Shawnee County is a part of that. As you can see, our peak currently is higher than the peak that we experienced several months ago during Delta. It is not as high as we experienced last year, but as the hospitals will point out, last year we had a lot more staffing, and so the difference in staffing is really making this the difference in our peak. Now this is all adult hospitalizations, but what about ICU adult hospitalizations? Actually, that's showing a slightly different story. We have more patients who are hospitalized in our ICUs than we ever have during this pandemic. And again, as a reminder, this is with shorter staffing to try to take care of these patients. Just take a moment to reflect on the deaths that we have experienced in Shawnee County. Nearly 500 individuals who live in Shawnee County have died thus far in the pandemic. That's a rate of nearly 3 people for every 1,000 residents who live here. And that is a slightly higher rate than what we have seen in the state as a whole and also in the country. You will note that the majority of our deaths occurred before the vaccine was available. And so that even during that Delta wave that we experienced several months ago, we had a really good protection, particularly of our elderly, vulnerable population and our long-term cares and such. And so our deaths, fortunately, were much lower during that wave than before. Okay, so Omicron. There's a lot that you could say about Omicron, but I just wanted to touch on the basics. Omicron is the variant that is now dominant in Shawnee County. It showed up in the world just a little over a month ago, and it has spread rapidly all around the world. And once it arrived here, it very quickly took over. And so it is the dominant variant in Shawnee County. It is very contagious, and it seems like with every variant, we say this one's more contagious than the one before, and this is very true. Delta was more contagious. This is far more contagious than Delta. It is capable, as we have seen in the numbers, of infecting a large number of people in a short amount of time. One of the ways that it does this is it has mutated enough to evade the immunity that we have, sort of what I describe as that hard-won immunity, either through a past infection or being vaccinated. And as such, there is a higher chance of reinfection. Some of the initial studies are indicating that previous infection really offers very little protection against being infected again and is not something you would want to rely on with Omicron. In addition, we really need to get that booster dose to your vaccine to have the protection that you had against Delta. So the 2 doses being fully vaccinated against Delta was very, very protective. Those 2 doses are no longer as protective against Omicron. And so getting that booster dose really gets you back up to that protection. Now, there's a lot of talk about severity. This is all the talk, to be honest, because we hear the initial data out of South Africa, where Omicron originated, was really indicating that even with the higher cases, they weren't seeing the hospitalizations that you would expect from such a high case rate. It is difficult to compare our population in the US to the population in South Africa. And some of the research that's been coming out indicates and agrees that it is not as severe as Delta, but it still remains more severe than the original version. So this is not a virus to take lightly. It is still something that we need to pay attention to. And both national data and also worldwide data indicate that hospitalizations increase in areas that have Omicron. Okay, just a word on outpatient treatments. When we started this pandemic, we didn't have a lot of tools to really combat the virus. But over time, it's now been almost 2 years, so we've had some time to try to create some outpatient treatments that can prevent someone from needing to be hospitalized and can save their life. One of those treatment groups, I should say, are monoclonal antibody cocktails. A few weeks ago, we had several different cocktails that we could choose from. However, only one, sotrovimab, remains effective against Omicron. So we had quite a number of options for this, and those options have been removed. Now, this means that sotrovimab is in demand all over the country. And as such, there's very limited allocation to each state, and then the state further allocates that to our health systems. KDHE announced last week that no facility in Kansas received more than 12 doses of sotrovimab. I just want to, probably need to say that again. We had 1,500 cases. We had maybe 12 doses of sotrovimab. So it is clear that the supply is not enough for the demand, and this is being rationed to the highest of the highest need. Another new outpatient treatment that has been developed are oral antiviral medications. This has been in the news in the last few weeks because they've just had their EUAs approved. And the first is Paxlovid and the second is molnupiravir. Again, very limited allocation to a limited number of pharmacies. Last week, my understanding is that fewer than 500 doses were given to the state of Kansas, and they were distributed to 16 different pharmacies, only one of which was in Topeka. Again, supply not enough for demand. So we cannot, at this point, rely on outpatient treatments to prevent hospitalizations. Let's see if I can get this here. Okay, just a moment on our vaccinations. I've circled here our fully vaccinated population. So as you can see, just under 60% of the entire county, and this includes everybody, just under 60% is considered fully vaccinated. So that's actually, that's the majority. We've worked really, really hard this last year to get this to the number that it is, and I'm really pleased that we've made it this far, because if we did not have this level of protection in our community, we would be in a much worse state than we are right now. That being said, 4 individuals out of every 10 who are walking around in the community are unvaccinated and are currently vulnerable to disease and vulnerable to hospitalization and death. Of those 60% who have been vaccinated, 40,000 have received a booster. That's an estimate based on current numbers. Vaccines remain widely available. So unlike some of these other things like the outpatient treatments that I was talking about and testing, vaccines are not in short supply. So if you want a vaccine, you can get a vaccine, and I would recommend this for everybody who has not yet been vaccinated. We do have one mass vaccination site that continues in Topeka. It's at the Kansas Museum of History every Thursday and Friday. We also are offering vaccines at the health department as well as multiple pharmacies and healthcare settings. And so when you're looking for your vaccine, I recommend starting with vaccines.gov. And this is just a map I took over the weekend when I was searching. You can see how many different locations are offering vaccines. Okay, so I'm not sure if we've talked about isolation and quarantine in one of our meetings before, but I think it's important because it just changed. So 2 days after Christmas, the CDC updated their guidelines for isolation and quarantine. They've actually done a couple updates on it since then, and so I wanted to try to simplify it for people in their minds when they're thinking about it. So as I am sure everyone knows by now, isolation is for individuals who are actively positive. Quarantine is for those individuals who have been exposed. So the rule to kind of remember is the 5+5. When you are positive, please isolate at home for 5 days. That's when you're considered to be the most infectious. And then after you have done your home isolation for 5 days, you are able to go back out into the community. However, you do need to wear a mask for an additional 5 days. This is because a smaller number of individuals remain infectious beyond those 5 days. And so it's difficult to predict who those individuals are. And so the 5 days of mask wearing really helps protect others as you are out there if you may be infectious. The same is true for quarantine. When you are exposed, they ask that you quarantine at home for 5 days. And then once you've completed that 5-day quarantine, you're able to go back out into the community, but asked to wear a mask for the same reasons that most individuals will become positive in the first 5 days. That's the science that is around Omicron. However, there are going to be some individuals who start to become infectious beyond those 5 days. And it is recommended to test at 5 days if you have that available. So the number 5 is really the number to remember here. Now, I do want to point out that if you are an individual who is unable to wear a mask, we would ask that you spend those 5 days that you would otherwise be out in the community, spend those at home, because you're not able to wear a mask. You can remain infectious, potentially infectious to others. Now, this is a very simplified version. There's more detail available at both the county website and the health department website. Okay, so to kind of summarize where we are and what we can anticipate based on what we know about Omicron. Looking at how it has impacted other areas like South Africa, like London, like other states, like New York, for example, in the US, we are estimating that cases are going to continue to increase for at least 3 more weeks. We will continue to see record highs each week as this progresses. With that, and again, comparing ourselves to what has happened elsewhere, we anticipate that hospitalizations and deaths will increase. This is because just the sheer volume of cases, as I mentioned, we have a large portion of our community that is still vulnerable. If we have the virus moving through them at a really rapid rate, we are going to have a lot of vulnerable people all become sick all at the same time. They will all be requiring hospitalizations, and that will be placing further strain on our healthcare system. This is not only going to impact those individuals who are in the hospital for COVID, it will also impact those individuals who need medical care for non-COVID reasons, but there are not beds available. This peak for hospitalizations and deaths, just based on past experience, will usually comes a few weeks after our cases peak. So right now we are estimating that will occur in February. For businesses, what we are expecting is a wave of employees who will become sick and unable to work. I anticipate that this will mean intermittent closures among our business communities, among our businesses in the community, as they are unable to maintain their operations with too many employees out sick. I know they've already been dealing with employee shortages and really don't have a lot of room to lose someone who's unable to work. Beyond just the county, because the whole country is impacted and also the world, our businesses will need to anticipate further disruptions to their supply chains. We're already seeing that even with the monoclonal antibodies. We can't make those enough because we have supply chain disruptions, and so our businesses will need to be prepared for that as well. Just as employees will become sick, we will also see a wave of students and teachers becoming sick. That's already started as schools have restarted this semester. And with that will come disrupted learning, as well as rescheduling of sports events and other extracurriculars due to illness and quarantine. Any questions?
Just for the sake of efficiency, I'd like to probably just hold all our questions until these first few presentations are done.
Okay.
And then we can come back and ask questions maybe after Dr. Cooley presentation.
Okay. Now I think I may need some help with the Zoom. Perhaps I can. How can I? Can I have my Zoom guy help here? And Commissioner, I understand you're going to introduce or move us through the agenda?
Yeah,
Okay.
so the next update would be from Stormontville Health.
Okay, it would be Dr. Dishman.
Thank you. This is Dr. Kevin Dishman, Chief Medical Officer at Stormontville. Can you hear me okay?
Yes, we can.
All right. First, want to thank the commissioners.
First, want to thank the commissioners for this opportunity to discuss what has become probably the defining moment of certainly my career, and I'm sure my colleagues could
echo that.
Currently, we're seeing 56
COVID patients. We're seeing about
20 of those in the ICU.
At this time, in counter to what you heard from earlier in this pandemic, we are utilizing about half of our 50 ventilators, about half of our ventilatory assistance machines such as BiPAP and high flow. And so the good news is that currently, as far as personal protective equipment, as well as machines to assist ventilation, we are currently in a reasonable state. Currently, we have approached vaccination in terms for our staff. We have achieved that. We did have one employee who was discharged over the inability to get the vaccine, and I do want to speak to that just for a minute. We had a total of 51 of almost 5,500 employees who left voluntarily and cited the vaccine as the reason that they were leaving. Most of those people were in ancillary and support roles. Our bedside staff is fully vaccinated. The real key to that is ensuring that we keep our staff as safe as possible so that we don't lose more of them to COVID. And the risk is not here at work. The risk is in the community. And by and large, all those cases have been contracted in the community. Your hospitals are safe. Your staff at your hospitals are safe. And we continue to see an extremely low level of transmission here in the hospital. And I think that's an important point. As Dr. Locke mentioned, testing, we have seen a dramatic increase of over a third of our tests are coming back positive, indicating that there is abundant spread within the community. The important message there is there are things we can do to mitigate this, and we've spoken to this many times, the importance of wearing masks, the importance of being vaccinated. At this time, we have reached a point knowing that the major reason that people have left the healthcare industry is because of the sheer ask of what is happening within healthcare at this time. We know that across the country, 20% of our medical staffs have left the practice of medicine, have left the industry, and that is a huge impact. And that's an impact we're feeling here in Shawnee County, as well as across the entire nation. We ask at this time for leadership to find a way to help us help you. And by that, I mean, can we find a way to encourage the use of masks? Can we find a way to ensure that everyone not only gets vaccinated, but also gets boosted, and bring down the ominous Dr. Locke placed before us? Our staffs will continue to care for this community. As I'm sure all of my colleagues that will present today can also tell you, that they are going to find a way. The problem is that that's going to require of them what has been an ongoing monumental effort, which began over 2 years ago. More will become tired, more will become exhausted, and there will be a mental reckoning for this task. We can ameliorate that, we can mitigate that, and would ask for your assistance in doing so. And at the end, I'll be happy to take any questions.
Good morning. This is Dr. Hyland, and then I'm the Chief Medical Officer here at St. Francis, and then we have Steve Anderson on the call as well, and he'll follow my presentation. I really do appreciate the opportunity to be able to let you know how things are going at St. Francis and with the medical community. As I know you're aware that things are stressed here at both health systems and within the community. So today we have 39 positive patients. We do have, let's see, 15 in the critical care status, 1 in progressive care, which is just kind of 1 level below that, and 23 medical status. Our ICU is full. We're over capacity. We're at 122%. For our ICU today. We have overflowed into our recovery room, and decision really to halt. For the last several weeks, we've been managing the hospital volumes by kind of who we're able to accept based on staffed beds from direct admits, who we were able to transfer out. We were balancing the surgery schedule, had to cancel several elective total joints over the last several weeks. I think we had a total of about 15 patients who, went through a very long process to get their joints replaced or in a lot of pain, having to reschedule those. And then we made the very difficult decision last Wednesday really to stop all electives. The surgeries that we're doing now are really urgent, emergent. We are moving forward with cancer cases and those that are related to relieving pain or any neurologic injury for patients such as spine surgery. Some of those surgeries are being canceled depending on what kind of level of severity their disease is in. We have mobilized nursing from different areas. We do continue to have our clinics open. Continuing normal care is very important at this time. So we haven't deployed a lot of staff from our clinics into the inpatient arena. Number 1, because it takes a lot to get those individuals up to speed. Number 2, we want to continue preventative care and keep people from being admitted to the hospital. So that's very important. As far as the patients that we're able to accept, I don't know if anybody was able to see the CMO call, the statewide CMO call last week with Dr. I believe it was Dr. Watson, who presented how this is affecting the whole state of Kansas and the critical access hospitals. And I know Stormont has a centralized, kind of their transfer station where they're working very closely with those critical access hospitals and managing patients there. We do not have that capacity at this point. But they have seen a 5-fold increase of patients from critical access hospitals across Kansas not be able to get to the level of care that they need to and expire. And that's both COVID patients and non-COVID patients. So those having heart attacks, those in car accidents, those having strokes are not getting standard of care in the state of Kansas. Or really in Topeka. I think, we're having to modify some of the care that we give because our staff is out. We're at critical staffing levels, across the organization. And then we have 46 associates out today, and that's only COVID related. I have talked with several managers and directors that have other staff out related to, their kids being home that are sick from school. We have one nurse who was positive, was going to return today, but now her children are positive. So she has to stay home and care for her kids. We have another nurse who can't come in because he needs to stay home and take care of his kids because their daycare center had to close because they had exposures at the daycare center. So anything that happens out in the community affects staffing at the hospital. And we do have amazing frontline staff here who want to help care for anybody who walks through our doors. And what we're asking is for the community to do two very simple things. And we don't want to take away any freedom from anybody. We want to have a normal functioning society where we can care for each other. We need to come together, and what we need from the community, what the healthcare needs from the community is when cases are rising like this, is to do the simple step, just like you cover your mouth when you cough, put your mask on just for the next few weeks and get vaccinated. They are safe. They do have side effects, but nothing like what you would experience if you were to get COVID. So that's our request. I don't want to, this is not political. This is purely just from an infectious disease standpoint and what we can do as a health community, to prevent both hospitals from becoming even more overwhelmed and not being able to care for our community members. So I really appreciate the opportunity to speak today. And Steve, I don't know if you have anything to add.
Yeah, good job, Dr. Hyland. Just one basic comment. I was asked the question to address the question of reimbursement for COVID patients. And what I would share with you is it's really about, number one, we care for any patient who comes our way that we can care for. Obviously, we are not able to care for all the patients that are trying to get into our hospitals here from the outlying areas because we don't have enough staff and we're overwhelmed with patients. But the resources to care for a COVID patient are significantly more intensive than caring for a non-COVID patient. So our costs to care for COVID patients are extremely high. And frankly, as hospitals, if you want to look at the finances of it, we would be far better off if COVID had never happened. So we're not here to try to benefit from what's going on. We certainly are taking care of all the patients we can, but the COVID patients take far more resources and costs to care for than non-COVID patients. So again, we'd be better off financially if COVID had never happened. So if there's any myth out there that we're benefiting from this, that's completely false. Thank you.
I would also like to add one of the things that, why elective procedures are kind of such a hot button topic. Number one, people need the procedures to be done, but that really is one of the financial engines of a hospital, not the medically sick COVID patients that are coming in. And we are not able to accept a significant portion of the COVID positive patients that are coming in from the critical access hospitals. And because we have the nursing staff that know how to take care of those post-surgical patients, that's a population that we've been able to accept. I was shocked yesterday. I went over to, review what direct admits were requested yesterday, and we were not able to accept someone who had appendicitis and someone with a broken hip. I don't think I've really seen that yet. So if you think that there's any financial incentive from the hospitals, what we ask is to be able to care for patients in a normal fashion, just like the community needs to have their businesses run in a normal fashion, and masks and vaccinations will allow that to happen.
Well said. I would agree with my colleagues. Everyone we're admitting to the hospital meets medical necessity. And by medical necessity, it means they need to be in the hospital. And so whether they have COVID, whether they're having a heart attack, whether they're having a stroke, as Dr. Hyland said, we're just trying to take care of not only the COVID people within our community, but all of the other medical problems within this community as well. And all those patients meet medical necessity, and it certainly does not incentivize us to prioritize COVID above any other diagnosis.
Operations Manager for AMR here in Topeka, Shawnee County. My boss, John Antrim, the GMR Regional Director, is also on the call. I just want to give you a couple quick updates on us and what we're doing. Last year, AMR in Shawnee County responded to 31,449 calls for service from the 911 system or from people calling us directly. Of that, we transported 17,456 patients, and we're seeing an uptick on those numbers already this year, with only us being in day number 10. Each day I staff 5 ALS trucks during the day, meaning they have a paramedic and an EMT, and 2 BLS trucks, which is just 2 EMTs, and at night that number goes down to 4 ALS and 1 BLS. We're seeing some staffing issues. We've been short a couple paramedics since the pandemic began. 4 is our current number of need for paramedics, and we also need 4 to 7 EMTs to be fully staffed. So of those numbers, of the 5 ALS trucks during the day, we're probably running with 1 short, and we're probably running 1 short at night. So we have a couple things that we're able to do with that. One of them is that myself or my leadership team will staff on the truck with the EMTs and paramedics to bring our numbers back up, or we're able to get another EMT and we'll create another additional BLS truck. Currently, I have 2 EMTs out with COVID. And we also have some others out with work-related injuries. One that had a recent surgery, and we're in seasonal flu season as well. PPE-wise, we're looking good. Our national stockpile from GMR has reached almost 20,000 protective masks, but if this pandemic goes for any length of time, we'll burn through those rather quickly. And as Dr. Locke mentioned, we have the supply chain issues. And that not only affects our ability to get medical supplies, but it affects our ability to get parts for our vehicle repairs. So we're having some issues getting some stuff to repair our vehicles. Our fleet's in good shape. Our staff's in good shape at this time. We have those minor challenges. Mitigation strategies, we have pretty much isolated the other first responders in the community from COVID. Anytime anybody calls the dispatch center at Shawnee County, they receive a medical screening questionnaire. That questionnaire covers whether or not they've been exposed to COVID likely or have COVID. And if that's the case, we're not sending our first responder partners to the calls. So we have the fire departments semi-isolated. We can't guarantee that everybody's accurate on their information. So I'm sure that there are some people that are missing our mitigation strategy. But we have that redundancy built in that as my staff is affected, hopefully the fire departments aren't. We can do some resource shift if we need. Our big problem right now is what the hospital's already mentioned. They're full. They're full, and that's the only place that we can take our patients. You know, by law, an ambulance service can either leave somebody at home or they can take them to an emergency room. We have discussed, and I'm sure that you're aware of our strategy to get the nurse navigation line up and running, which will allow us to get the patients to different places in the community, whether it's Grace Med, whether it's the Topeka ER, one of those other facilities, so that we take some of that burden off of the hospitals. But we're trying to take those patients as we see them in the public that aren't acute. The people that have some of the symptoms, we're trying to convince them that, hey, at this time, please stay at home, and we work with our medical director on this. Please stay at home, and if things change, call us back, and at that time, we'll take you to the hospitals. So with that, I'll break and let the next presenter, unless there are questions at this time.
I appreciate it, Mickey. John, did John Antrim have anything to say as well? Okay, doesn't look like it. So next up would be Dr. Cooley with the Public Health Technical Advisory Board update.
Good morning, Commissioners. It's been a while. Good to see you all. My name is Dr. Dennis Cooley. I chair the Public Health Technical Advisory Board. I'm going to be brief in my comments. I want to update you on a December 31st meeting of the Public Health Technical Advisory Board. The purpose of that meeting was to get feedback and updates from community partners on COVID and Omicron. The groups that attended this or that we included in this were the Shawnee County Health Department, our hospitals, asking them about inpatient, ER, and urgent care capabilities, EMS and ambulance services, long-term care facilities, school nurses, and the physician community through a representative from the Shawnee County Medical Society. You already heard from the Shawnee County Health Department, hospitals, and AMR, so I'm not going to go over that. Although I do want to mention one thing that I think maybe wasn't mentioned at the hospitals, and that's the ER situation. And I think our hospital representatives may be able to comment on this too, but right now our ERs are swamped, and they're having to border a lot of patients. And what that means is that patients in the ER would normally be transferred up to the floor, but there are no beds. So they're staying down in the emergency room. This puts a tremendous pressure on the ER staff because they're not only having to do their ER work, but now they are essentially managing these patients as they would on an inpatient floor. And our urgent care clinics are also swamped. They're having difficulties because many times in urgent care, you have a patient who is more seriously ill than what they can manage. And what they do then is they send those patients or transfer those patients to emergency rooms. They're having difficulties because those emergency rooms are full. So let me get to the main area that I was going to talk about. Start off, we'll talk about the long-term care facility issues. Staffing is the biggest issue they have. They are unable to fill available beds as a result. And this again goes back to the hospitals. Hospitals need to transfer patients once they're capable to go to maybe a long-term care facility. Those long-term care facilities are unable to accept them, so those patients have to stay in the hospitals. They're seeing an increased case in the positive number of cases in their residents. So this is requiring that those residents be in isolation and quarantine. And I can just tell you a personal story about how that affects the residents. My 95-year-old mother-in-law is in an assisted living situation. She suffers from dementia, and this has been tremendously stressful on her when she is forced to go into isolation or quarantine. Also, when you have more of your patients, your residents who are positive, then this is requiring increased testing. So again, they already have a thin staff, and now the staffs are required to do more of testing. And there's certainly from the long-term care facilities concern about where money is going to come from for this testing if it dries up. Right now it's being covered, but there is concern they have about that. The next group was our schools. We talked to school nurses. Omicron has had a huge impact on our schools. As more cases occur, it increases the work already needed, or that the school nurses have to do. School nurses are wonderful people, and they are busy without COVID. You add on COVID, and the amount of work that they're forced to do is increased dramatically. We all want schools to stay open. I think everybody agrees. And so because of that, they have what's known as test to learn, test to stay, test to play, etc. These are testing protocols that allow students to attend in quarantine, but they have to be tested. So this is putting more burden on our school nurses. And quite frankly, they're working harder and they're experiencing burnout. And you heard a little bit about this from, I think, our hospital folks about what the burnout is with our healthcare workers. They are doing extra work, and they feel like that they are in hostile situations with many parents who are actually not appreciating that they're trying to help their children and to keep the schools open. Instead, they're just being met with hostility and anger. And I'll finish up with our community physicians. and outpatients. They also are feeling stress from the increased patient loads that they're seeing. These patient loads are requiring them to cancel things like well checkups, preventative care, just like what we're seeing with hospitals when they have to cancel surgeries. They are also suffering from staffing issues in your offices, our doctors' offices, et cetera. They're, as I said, unable to perform their preventative care. They really are feeling, at least they're expressing that they're feeling stressed out because they know that they're not performing optimal care. Dr. Hyland pointed out that our standards of care are suffering, and physicians and our healthcare workers don't feel good about that. They are stressed by that. They feel terrible that they are not able to do that. And they're feeling burnout, just as I said. Not only are they feeling that they have to work harder, but they also are feeling that that's not being appreciated by many in the community. So I'm going to summarize just some of the common themes that we're getting. Increased workloads from just the sheer number of cases, and they're all being asked to do more. Staff issues are probably the biggest concern right now. This is making their workloads higher, and it's preventing optimal care. And finally, and we're very close to being in crisis standards of care. And we've already experienced some of that. Crisis standards of care is just a fancy way of saying rationing. Okay? And we're already seeing that. We're seeing that with monoclonal antibodies. We're seeing that with our antiviral meds. And I think we're seeing it with our preventative care. So these are, I think, the reasons why we're seeing so much burnout, and why we're seeing healthcare workers who are suffering, and why we're seeing people who are quitting. So I'll close with that. Thank you.
Okay, at this time we'll pause from the agenda for a moment and go ahead and take questions.
All right. The federal government had a national pandemic plan for dealing with respiratory viruses. And step one was to find drugs that would help people, to keep them from going into hospitals. What happened to step one? Where did that go? It's like we dropped the ball on that. I don't understand how that could have happened. We talk about the workload, or let's talk about shortage of testing. Who's responsible for these tests? Is this something that comes from the federal government? Is this something that comes from KDHE? Who's responsible for the testing where we have a shortage?
Commissioner, is that directed at a certain?
Yeah, that'd be fine.
Dr. Aaron Locke, Health Officer. I understand, Commissioner Rippon, the question is about the source of tests?
Testing, yeah. Why do we have such a shortage?
Well, I think the big picture on that is the demand at this point. We just have such a need for testing that we're not prepared for Omicron. It has arrived very suddenly on the scene and has dramatically increased the need for tests.
Who disseminates these tests? Do you call up a company to get them, or do they come from the KDHE, or you call the feds?
Sometimes I'm asking the same questions about where these tests are coming from. There are a multitude of tests that have been authorized to be used for COVID-19. They come from various different companies that are producing the tests. For example, Abbott is a very common household name anymore because of the Binax Now that's available over the counter. That's just an example, not a commercial for them. So depending on the supply chain, so for example, our long-term care facilities are receiving some tests through the state. They're also receiving some tests through federal distribution and sort of partnerships that have been set up by the federal government with manufacturers and suppliers of that. Others, it's a federal pharmacy partnership where tests are being manufactured and then they are being sent to the pharmacies for distribution. So there are multiple different channels, and I apologize, I'm not an expert on sort of the logistics of it, but everybody is going to be getting their tests through slightly different mechanisms.
The monoclonal antibodies, that cocktail.
Mm-hmm.
I think somebody said earlier that the federal government is disseminating those, and so much goes to each state, and we got like 12, something like that here in Topeka. That's catastrophic failure for getting us those, and I take it they work. They're very effective.
They are very effective, yes.
And we can't get them.
That is correct. The first monoclonal antibody, I think, was very famously used by former President Trump. That was Regencov near the end of 2020. So it took us about a year to get a monoclonal antibody cocktail really developed and authorized for use. During 2021, we had multiple others come online. I should also back up and say bamlanivimab was another one at the end of 2020. But then we've had others come online. We were using them in 2021. The stock seemed decent at that point. And then Omicron has, as I mentioned before, basically wiped out our ability to use the cocktails that we were actively using and producing. So Sotrovimab, on the other hand, is relatively late to the scene. It has never been available in large quantities. And so that manufacturer, as I understand it, is attempting to really increase production, but has not yet done that at this point.
Wow. This is a question for maybe Dr. Dishman. You said you have a lot less staffing this year. Are you, Dr. Dishman?
That's it. Yeah, that's correct.
Lower staffing.
We're at lower staffing than we were during the previous surge, and we're seeing this across the state and across the nation.
Where did they go? Did they retire? Did they move on to something else, or?
All of the above.
All of the above. I think that we've seen retirements, and I'm speaking for the healthcare industry at this point. We've seen retirements, we've seen movement to other industries, and as I said, a lot of that movement is
occurring in our support personnel. And just because they're not at the bedside doesn't make them any less important. In fact, they're critical to our care pathways and to the way we deliver healthcare. We're seeing migration away from healthcare to other sectors of industry, particularly in IT, particularly in the cyberspace, and particularly in other ancillary tech positions. So we've also seen nurses simply leave the bedside because of the added workload, the added stress, and the demands that are placed on them every day. You did make a good point, Commissioner. I think this is catastrophic, and so if I may back up to your first statement, this makes prevention what the biggest mitigation strategy we have. There, as you pointed out, it's catastrophic. At this point, it does not appear that there's any cavalry to ride to the rescue on the horizon. And so, again, I think that prevention, just like we've done with hypertension, to prevent strokes, to prevent heart disease, and prevent renal disease, I don't believe can look to a large number of dosages of monoclonal antibodies showing up on our doorsteps. I don't think we can look to an immense number of tests flooding the Topeka area. I think what we've got to do is we've got to find a strategy that makes it so we don't need as many monoclonal antibodies, so that we don't need as many tests, so not as many people become symptomatic. And so that's why I think we need to focus on prevention. Sorry to jump back to your previous question, Commissioner, but I think it was a good point.
I guess why quarantine nursing personnel due to exposure if they feel well? Why not have them just wear PPI and avoid lengthy contact with patients? Would that help?
So throughout this pandemic,
we worked closely with Dr. Locke and her team to ensure that we are following all CDC guidelines for quarantine and to ensure
we're returning people to the bedside as safe as safely and as quickly as we can possibly do so. We've recently seen, and Dr. Locke could expand on this, we've recently seen this, as she stated, the CDC adjust that quarantine period. And there's also crisis staffing, which we can talk about as well, which allows us to return people to the bedside. We know that by wearing personal protective equipment, face masks, face shields, our isolation gear, gloves, washing hands, and then even when you're not at work, making sure that you social distance, don't go into large groups, really, again, focusing on prevention for our staffs to ensure we have as many people available to provide care.
Okay. Have we looked at other, you say the cavalry's they're not gonna show up, cavalry. I noticed some states are using National Guard people. They're bringing in nurses from other countries, Indonesia, Malaysia, Canada. Are we trying to do anything like that? Yeah, that,
Okay.
yes. Dr. Dishman?
I think Dusty's.
Oh,
I
Dusty.
can pick some of that up, sir.
Okay.
Dr. Dishman, I can share this answer with you if you like. Emergency management does monitor these resources, which is why we put in the declaration, because we knew we were going to have resource shortages as this cropped back up. The National Guard is part of our community, so they are working probably at a hospital or
Okay.
other businesses. That's what they do. So they are suffering the same hits as everybody else is. As far as the cavalry goes, I think Dr. Dishman's correct. There's no real cavalry. We individually are the cavalry, and wearing your mask and getting vaccinated is the way you do it. So we can request, but there's very limited things that the National Guard can do for us right now.
What about bringing nurses in from other countries?
I think that's being explored at the state level as well. Maybe Dr. Locke or Dr. Dishman can mention something about that.
Dr. Dishman or Dr. Hyland, would you like to comment on that?
We currently have a program that's utilizing nurses that are trained overseas. Of course, we have to ensure that those nurses have the highest credentialing, the highest possible skills, and we've been very successful. And we've been doing that. Well, I can attest that actually Select Specialty Hospital, when they were here in town, began that process over a decade ago of attracting talent to the Topeka area and being able to employ that talent, and then getting them, motivating them to stay in the Topeka area. And so that's been a successful program that I believe both facilities have worked with for some time. Now, unfortunately, that again, that's not a large number of nurses at this point, and I think that we'll continue that process and continue to look not only overseas but to any possible avenue. You know, that's the difficulty with having everybody in the country in the same position. We're fighting each other for staff. You know, one of the happy side effects, I guess, if you could, of this COVID pandemic is that a lot of barriers between hospitals have come down. We've been forced to all work together more so than ever before. And I know this is true for myself and Dr. Hyland, Dr. Locke, and all of us together. You know, what we're trying to do is ensure that we can work together to take care of the entire community. And I think, again, Commissioner, as you say, I think that's an avenue to look at. Again, I'll echo Dusty's comments. Our National Guard people are our nurses and our emergency room staffs and our ambulance crews, our paramedics, our EMTs. So they're a part of our community and already working in that stead. So again, great ideas. I think we're trying anything we possibly can at this time. Jackie, any comments? Don't let me dominate this thing.
Yeah, my comment is that I think everybody is kind of looking and trying to, you know, uncover different resources to help to get to the bedside, and we'll continue to do that. I think in the future we'll have pretty significant shortages as people continue to leave healthcare, and it doesn't look like a very attractive field for young people to go into. There's not a lot of appreciation now being shown to healthcare providers. But I think a critical aspect of this discussion is this is an acute issue. The healthcare, the hospitals here in Topeka are completely overwhelmed. And to bring somebody in from another country at this point takes time. And really the actions that need to occur is for the community to step up and help us and to put on their masks and to get vaccinated. So that is what is going to take the relief off the hospitals right now. And then we will continue to work on the staffing shortages as we move forward.
Well said, Jackie.
Dr. Hyland, how many staff people did you lose? Because I assume you required people to be vaccinated. Did you lose a large percentage of people for that reason?
We work very closely with our staff. There was a lot of communication, a lot of education. 100% of our staff is compliant with our vaccination policy. We do have a very small portion that did get both medical and religious exemptions, and we had a panel that reviewed those requests on an anonymous basis. We did not know who was requesting those exemptions, nor where they worked. So I think it was a very good process that we went through. It was very respectful. I do want people to know that we respect their beliefs, their concerns, their fears when receiving a preventative treatment. We also want to keep people at the bedside safe. We want to keep our patients safe. So vaccination is definitely the best way to do that. And we have a portion of our population that is working at the bedside that is wearing their PPE. Unfortunately, are not vaccinated, but it is a very small portion of our population. And I think we lost one associate over the vaccination concern.
That concern. How many did you lose, though? How many people in total did you lose?
How many people in total did you lose that did not, that because of the vaccination requirement?
Just the left period. How much lower is your staff level now than it was, say, a year ago or 2 years ago?
So from the vaccination, from total people that have left, Steve, I'd have to have you kind of comment on total.
We're down about 10% from last year's staffing.
But significant agency, we have lots of nurses that have left to do agency nursing. And then we have a lot of agency nurses here, just because at this point they can, they get paid a lot.
Maybe this is for Dr. Locke. What are we doing to try to prevent people from getting so sick that they have to go to the hospital? Is there any kind of protocol? Is there drug use? What do we have? What kind of arrows do we have in our quiver to keep people from going to the hospital? What are we doing?
Well, I can echo what Dr. Hyland and Dr. Dishman have been saying, that prevention from becoming ill is the best way to avoid being in the hospital. And so that means really our arrow is the vaccine. The vaccine is going to prevent people from going to the hospital. The second would be wearing a mask. It protects you from that virus. It will prevent you from getting infected.
There's no preventative drugs?
So as we have mentioned before, we have sotrovimab, we have Paxlovid, molnupiravir. We can get into the details on that. Those are, when someone has tested positive, if you get those going in the first few days, very, very effective at preventing people from hospitalized. But
are they readily available?
They are not. So at this point, it is prevention. It is prevention, prevention, prevention.
It's hard to imagine after 2 years this is the best we can do. We're down to a mask. That's our prevention?
And the vaccine.
And the vaccine.
That's another question. What is fully vaccine now? What does that mean?
I can take that.
Sure.
Yeah. So the definition of fully vaccinated has really changed without actually changing the definition. So previously, with the Delta variant, you would be considered fully vaccinated, very protected, if you had 2 doses of Moderna, 2 doses of Pfizer, or 1 dose of the J&J. With Omicron, that has changed. Those 2 doses or that single dose of J&J is not going to protect you against Omicron in the same way it was protecting against Delta. And so we really need to get that booster dose if you are beyond that protection window. So for the 2 doses with Moderna and Pfizer, you have a 6-month protection window. Beyond that, you really need that booster to maintain your protection against Omicron.
What about people who have already had COVID and they have some natural immunity?
Yes. So previously, we would consider an individual who had had a previous documented infection to be protected against Delta and so on for at least 6 months. In fact, I had it written into our quarantine exemption that if you had been infected, you did not even need to quarantine. However, as I mentioned with Omicron is a bit of a mutant variant. It has a lot of changes in it. And because of that, our immunity does not recognize it the way it recognized Delta and previous versions. Therefore, the protection that a previous infection would give you against Omicron is much, much lower. At this point, I would not rely on a previous infection to prevent me from being infected again.
Okay. I'm sorry.
Could I ask a follow-up question real quick? On the previous infections question, just to piggyback off of his, maybe a question for the hospital representatives, either one of you. We know that a high percentage of the folks that are hospitalized currently for COVID are unvaccinated or have had quite a while since their last vaccine. Of those, do we keep any statistics on how many of them have been previously infected? To know, does that help with the severity of the virus at all? Obviously, we don't want people to go out and get COVID to prevent future infection. That's counterintuitive, but are we seeing anything like that? Any trends?
So, Dr. Hyland, I don't know if you all are keeping that sort of data. We are not. Frankly, I think it would be a little difficult to get that. Here's what we do know from the science, that a vaccination followed by appropriate booster, and now with the recommendations of the CDC for an additional injection besides that, your ability of your immune system to fight the COVID-19 SARS-CoV-2 virus is heightened more by vaccination than it is by natural immunity from having the disease. That's why we go ahead and we vaccinate people a few weeks after they have their illness, even if they're hospitalized. So it's still important to get the vaccine. Commissioner, I wish I could directly answer your question, but I think it'd be very difficult to actually get the data of how many unvaccinated had the disease beforehand to be able to compare that. I'm sure there's someone smarter than I am out there that's doing that work. And Dr. Hyland, any comments in that?
Yeah, we are not tracking that. We will track whether or not they are vaccinated, and now really looking at whether or not they are boosted as well. But about 85% of those who are hospitalized and particularly in the ICU are unvaccinated. They have a much more severe course with COVID-19.
I can think of at least one study, although the name of the study is escaping me, where they looked at individuals. The entire group had an infection, but they split the group in two, and one group went ahead and was vaccinated, and the other group continued as if that infection was it was their only protection. And that group was approximately five times more likely to be infected again, as opposed to the group that had the infection and followed by vaccination. So I know that that's not exactly the question, but that does give us some indication of the protection levels that you can get.
Okay. Any further questions?
Yes, I had a question for Dr. Dishman. The Stormont Vale, was it Dishman? No, I'm sorry,
Yes.
I had the wrong.
Yeah, he's from Stormont Vale.
Dishman. I had a question about your scorecard that comes out. Back in October, one of the things you'd put on your scorecard was current hospitalized COVID-19 patients. At that time, you had 30, and it said percentage of hospitalized patients unvaccinated. It was 63%. But then, in November, it suddenly changed from percentage of hospitalized patients unvaccinated to percentage of admissions unvaccinated past 30 days. And then, in December, it changed again. It went percentage COVID-19 admissions unvaccinated or last dose/booster more than 6 months ago. Can you explain why they kept moving the goalposts here on this? This made it very difficult to follow or compare to what was going on last summer, say.
I understand your question, Commissioner. I'm getting an echo here, sorry. And thank you. What we have done is adjusted how we're reporting that as, first of all, as the vaccine became available, I think was responsible for the first change, which demonstrated that with the vaccine, you do run a lower risk of being hospitalized and certainly a lower risk of having a severe infection to the point where it becomes critical and life-threatening. We also learned as we went through this pandemic, just as we have learned all along, that boosters were necessary. And so that became the second change. I cannot promise you that you won't see another change. If it is confusing, then we'll strive to do a better job of communicating about why the changes occur and what their importance is. I think it's really important to keep the focus on the fact that we have made strides against this disease. We do know the vaccine works. We do know that you need a booster. And now today we do know that that there will be an additional injection required to provide full immunity. And we endeavor to be as clear as we possibly can. I don't think it's so much moving the goalpost as responding to the science as it becomes more available and we learn better every day how to treat, but most importantly, as my colleagues have said, prevent this disease.
I read a lot about different drugs that different doctors in different areas of the world and whatnot have used as preventative. Well, I don't know if preventative, but at least reducing the severity. Things like ivermectin and things like that. And it seems like ivermectin in this country has been locked down. Can you comment on that? Why that isn't more widely used?
Sure, I'd be happy to. One of the ways that we determine what best practice is through our independent medical staff who's responsible for credentialing and for the assurance of quality throughout not only our hospital, but they're charged with that in hospitals across America. One of the things they do is pharmacy and therapeutics. So after an extensive review by our pharmacists and our clinicians, led by Dr. Kim Bry and Dr. Sarah Sarton, who are our chief of staff and our president of our medical staff and
And can you hear me? It's Dr. Hyland. Yeah, so I can just comment on ivermectin. So the studies that I think some people are kind of referencing that it may be an effective therapy have turned out not to be studies that were well done throughout the pandemic. I think one of the things to get information out to physicians a little bit faster, a lot of papers were published that were not reviewed by their peers. And so a lot of studies got out there that were not well done. Ivermectin can be a treatment that's given under a study. And there are different studies that patients can be enrolled in to make sure that what we're giving to patients is an appropriate treatment for that disease process. Like what we saw with hydroxychloroquine and azithromycin at the beginning of the pandemic, it actually increased the mortality, and we saw a lot of cardiac arrhythmias and different things that occurred because of that combination of medication. So there, and what Dr. Dishman was speaking to was the medical staff process and credentialing that we go through to make sure that the providers that join our medical staff are trained and well educated. And then the pharmacy and therapeutics is a committee that all Joint Commission certified hospitals have to review what therapeutics are given to patients. And generally at most facilities that would be specialists on that committee that would review the treatments that are given. So it is looked at closely, and we do want to use treatments that are effective, and we do not want to use treatments that may cause harm.
Thanks, Jackie. Now you're finishing my thoughts.
Yeah, sorry. Yeah. I think we're probably the same process.
To review appropriate treatment.
Any other questions?
I guess not at this time.
Okay. I have a couple. You had mentioned, I think it was Dr. Dishman perhaps, that you guys had stopped with the elective procedures, surgeries. Obviously, a lot of those, they're called elective, but I know that a lot of them are necessary. Has the staff who is typically performing those surgeries and things like that, have they all transitioned over to, say, the ER and ICU and things like that?
Yeah, it's a multifocal approach. Really, the non-essential, which is the term I think that's nationally accepted now, the non-essential, non-critical, non-urgent patients at this time, it's really about opening beds. So it's really about if you can postpone a surgery that allows you to have a bed available, that surgery would have taken up, and be able to use that staff to address our critical and emergent COVID needs and non-COVID needs, then we're better able to serve our community. So it's really about purely creating as much bed space as we possibly can to ensure that we continue to offer that space and that care to our community.
To go off of that, I know that Stormont Vale and St. Francis both have a number of urgent care clinics, rehab hospital, cancer hospital, heart hospital, all of those things that kind of go outside of the acute care. Are those staff being transitioned back to the hospital as well? Or are you to urgent care rather than having them come to the emergency room and things like that?
Yeah, as much as we can. I mean, we do need to continue the care for, the cardiovascular patients, the cancer patients. There's a lot of outpatient medicine that's done that prevents hospitalizations. So a lot of preventative care happens in the clinic. So we don't overwhelm the hospitals where the very expensive care takes place. So that's one of the ways we keep costs down for patients in the community. So transitioning that care down the line, then what we found out from, initially in the pandemic when we shut everything down, we saw patients just get sicker. And we had a lot of very critically ill patients that we had to care for. So we've transitioned those nurses that have the experience for what we need in the hospital, but we continue to run our clinics as normal as we can. And we do sometimes ask, individuals to go to the urgent care clinic when it's appropriate from a EMTALA standpoint.
I would echo that as well. We've seen over a 30% increase in our express care volumes. We're still continuing to set new records every day in our drive-up testing, and continue to strive to staff those areas, as well as staffing the hospital, staffing the emergency room. Just the need during this pandemic across urgent medicine, express care, emergency room, acute care transfers, all those things has just dramatically increased. And Commissioner, directly to your question, it's an all hands on deck approach right now. If anyone who has the skills, we are utilizing them to the fullest of our ability and to the fullest of their capabilities. And I know St. Francis is doing the same.
I guess I want to ask a couple questions of AMR, if you don't mind, Mickey. I know that hospital transfers have been something that you guys have been doing, I assume. And so could you kind of speak to the number of hospital transfers you're doing and how that's affected your ability to provide typical ambulance care?
So my focus in Shawnee County is 911. That is our primary mission. That's our primary duty. And we do whatever we can to provide transfers for the hospitals, permitting that we do not impact the 911 system. So if we can't take a transfer for whatever reason, we'll try to reach out to our partners in Johnson County. My counterparts there, that's their primary mission, is to do interfacility transfers from hospital to hospital. We also have some small providers here in the community that we'll use. But realistically, we are maybe doing 1 or 2 a day just because we don't have the staff and the volume of calls is up. And so that, I'm sure, is impacting the hospital's ability to move their patients out as well.
Okay, good. My next question for you is with regards to the nurse navigation line. That's something that we've talked about in the ambulance advisory board meetings, a little bit here in the meetings. I think there's a desire to maybe use some of our ARPA funds to fund to that and get it up and running. If we were to do that, let's just say hypothetically that we approve that tomorrow, which can't happen because we don't meet, but if we did that, how long would it take to get that program up and running? Because, I mean, it sounds like it would be a great benefit, especially to those urgent care clinics and things like that.
So I
probably.
anticipate that once we get the get-go, it's going to take probably 45 to 60 days total, because the infrastructure is the easy part. It's meeting with all the community partners and coming up with the protocols that fit this county. There's a can set of protocols that we could just put in place, but that wouldn't necessarily be the best thing that we could do for the citizens here. So we need to look at structuring that program for us, and you know, that requires a great deal of involvement from not only the county government but also from the hospitals and the medical community, and that's tough to do right now because, as doctors have said, we're all hands on deck and we've got other things that are more pressing. So to sneak in another 2 to 3 meetings a week to try and do that in a rapid fashion probably wouldn't work. 1 meeting a week is probably doable for everybody at this time, and it's just getting those steering committees in place and getting that done.
Okay. Any questions for me?
Sure. I have a question about the vaccines.
Thank you, Mickey.
This would be probably a question for Dr. Locke. Why aren't any of these approved by the FDA?
Well, one of the vaccines is approved by
But it's
the
not
FDA.
available.
The others are authorized, as we've talked about.
Only the ones that you can get right now are through a emergency use authorization. That's it.
That's correct. Mhm.
What's the holdup? What's going on?
Pfizer.
So, as I understand, there's a usual process through the FDA. Normally, for a vaccine or a medication, it would take years to have something be fully approved. You really have to collect an enormous amount of information that would prove that something
Sure.
is safe. We put at the beginning of the pandemic, they really put a goal already with a vaccine in sight, even as things were starting to unravel in our hospitals and our cases across the country in 2020. We also had the vaccine in mind, and so individuals were already working towards that in these various vaccine companies. We have exceptionally good data at this point, but the vaccines remain under the EUA because that's what they started with as they were moving forward. That exceptionally good data has, from Pfizer in particular, was submitted to the FDA, and it was approved. At that moment, it then moves into a branding, and so it was branded as Comirnaty, and that is what is approved. As I understand it, anything that was manufactured before that point was manufactured under the EUA label. And so at this point, instead of tossing that out, because that's extremely wasteful in this day and age with vaccines needed around the world, they're continuing to use the vaccine that was manufactured under the EUA. That is my understanding of what is occurring right now.
But it sounds like they've bypassed some of the lengthy tests that normally a drug would go through.
Actually, I would say they did not do that. They actually had started, as I mentioned at the very beginning, working to sequence the virus, getting that virus, the data about it around the world. And so labs like BioNTech or Moderna began working on it immediately so that they could very quickly move into those phase 1 trials about safety and then into their phase 2 and 3 trials that were conducted with thousands of participants all around the world. We don't normally put such a high priority on vaccines, which is why it usually takes a long time. It also can take a long time in a study when there's a lower level of disease to really prove that that vaccine is working. So if you were going to try to do, I don't know, pick whatever virus or other disease you want to choose, it would take longer to get the data you need. But because COVID was so prominent, so everywhere, they were able to get that data very quickly.
But there's no way they could have done long-term testing
Yeah,
because it hasn't been around long enough to
certainly,
do
there's
that.
I hear that quite a bit actually about the long-term, the concern about long-term side effects. But when we look historically at vaccines that we are using every day for other diseases, really the side effects show up in the first 6 weeks. And so there's not a history in any other vaccine of something showing up 6 months or 6 years or 60 years down the road.
Well, there's some that we see them. I see the class action suits every night on TV from some drug that had some side effect enough to create a lawsuit.
Certainly. At this point, I'm speaking to the vaccines that we currently use.
I just don't know if this pandemic can be beat solely on vaccines alone. I think part of it's going to have to be herd immunity. But when we look at some of the new health orders, could it be that a lot of people will avoid testing or they'll avoid reporting that they're sick because they don't want to go into some kind of isolation or quarantine?
Yes, that is, okay, so I think your question is our reporting accurate of the number of positive individuals in the county at this time? Is that another way of asking the question?
No, I just wondered if people avoid reporting or because they don't want to be quarantined. Mm-hmm. Does that happen a lot? I would think it probably does.
Sure. After Dusty, you want to talk about?
They have a business to run or whatever.
During my service as incident commander over the past 19 months before that ended a couple months ago, yes, that's exactly what they're doing. Not everybody, obviously, but there are people that I know personally and heard rumors, of course, that people refuse to report. I actually think our numbers and cases are probably low. I think we have more than what's being shown personally. Yeah. They avoid it. They'll send their kids to school. They'll do all these things to work around it because they want to get the herd immunity or go around it. That is happening. You are correct.
What's the rate of recovery for somebody who gets the virus right now? What's their rate of recovery?
Ooh, I think that's a difficult question to answer, in part because as you have recognized, we don't have a good total number of who is infected. And if we had a good number on that, we would be able to really tell us a better rate of recovery. I think it very much depends on who you are. What is your age? What are your comorbidities? What's your risk? It also depends on if you've been vaccinated or not. I don't know if my hospital partners would be able to comment on that in any way. But as far as what you see in the hospitals?
I've seen polls before where they ask people, if you get COVID, what are your chances of being hospitalized or dying? Astronomically high. Astronomically high. Unbelievable. The poll I had, they actually split it out by Republican and Democrat. And among Democrats, they were like 50% of them thought they were going to be hospitalized if they had COVID. And so I don't know where the failure is there. And excuse me, is that
Okay. Could I just address the
Sure.
question?
So I think when you're infected with the virus, I think you can be anywhere from asymptomatic to death. There's a big, range of how people respond, and depending on their age and comorbidities. The issue is, we don't want anybody to be hospitalized or suffer from any illness. And as a hospital, we're here to take care of those who do get sick. The issue is that there are too many people getting sick. I don't know what the percentage is that are infected with the virus that actually have to come to the hospital. I don't think anybody knows the answer to that question. What we do know is that it's overwhelming St. Francis and Stormont Vale in Shawnee County right now. That's what we know.
We know that Omicron is going to increase our infection rate by as much as 4 times. Even a small number with a 4-time dramatic increase is still a lot of people in our hospitals and more people dying, and it is preventable.
And I would just add to that more people dying of other reasons, not just COVID. If there's not a bed available, you will die from a heart attack, you will die from a stroke, you will die from a car accident. At this point, we are all at risk.
Okay. Thank you.
I've got a couple of additional questions as well. I'll have Dr. Hyland, even though it's really a question for both hospitals, but I feel like you've done less talking than Dr. Dishman at this point, so it's your turn. So telehealth is something that kind of boomed as a result of COVID. Could you kind of speak to, how often are you using that? Has it increased the efficiency in which you guys provide care to maybe non-emergency situations?
We use telemedicine in a variety of different ways. Initially in the pandemic, both for inpatient and outpatient care. I think kind of where that really has been helpful is if someone is far away and they don't want to drive, to be able to do a patient visit that way. And we have had, I would say, a slower uptick than I would like to have seen with telehealth here at St. Francis. But it has been helpful, and I do think it can add efficiencies to care.
Is getting sent home from the hospital to recover. Is that something that you are offering to them, or is that something that you are saying, this is what we're going to do for your recovery follow-ups and things like that?
Here at St. Francis, we probably would offer it. We wouldn't make it mandatory. And it depends on if they're COVID positive and they're at home, that we would strongly suggest that we do a telemedicine visit. If they do have to come in, then they would come in through the emergency room, where, they're used to caring for individuals. And then we would put them in kind of the respiratory isolation portion of the ER.
Thank you. I do have another question here, and I'll just pick on you a little bit more here. But in terms of your hospital doing testing and vaccinations, we've got a number of places within the community that people can obtain that. My last count the other day, I think there's about 30 places in Shawnee County where people can get a vaccine. Are you guys still doing vaccines internally, and is there medical staff that is dedicated just to that?
are doing offering vaccinations to our patients. It is by appointment, and it's in all of our clinics currently. Yeah.
Providing vaccines, it's just if somebody's in for an appointment or something, you offer it, or
Yeah.
or how?
Yeah, it's
Okay.
become part of
Yeah,
the
it's
normal
become
care.
part of the normal care.
Okay, and then could you address the testing as well? I know you guys are doing testing internally. Do you have
Yeah.
a clinic going
Yeah.
on?
We did have
We
do
did
have it
have-
at
we do-
Brewster, but frequently over the last few weeks they have not been staffed to do it. We do have enough tests to be able to continue testing, but staffing has been the issue. And then the urgent cares is where the majority of the testing is occurring.
Thank you. And then Teresa, would you be able, or actually maybe Dr. Locke, either one of you, with the Shawnee County Health Department, could you kind of speak to our ability to provide testing and vaccinations through our resources?
Yes, good morning. Teresa Fisher, Director of Shawnee County Health Department. I will address the testing first. We recently, as in just late last week, were able to secure testing instruments to be able to at least always bolster up our efforts internally for our staff to be able to provide them a testing opportunity so they're not having to be gone for long periods of time waiting on their test results. I, along with all of them, am dealing with a staffing shortage. And so if I could have dedicated staff to run a testing clinic and then have an actual site of where that would be able to happen, that'd be what I need at this point. I have a very limited number of staff, really in a lot of my departments, to be able to do that. But we are working on seeing what we can do to bolster that up. We're exploring, we do have funding for staff, but at this point, as you've all heard, we're all vying for the same staff in this community. As far as vaccinations, we do have vaccines readily available. We offer those at our immunizations clinic over on 10th Street. We do take appointments only just because it's a small clinic in nature and we don't want a large amount of people in there. But anybody in the community can call. We do all the ages and all the shots and boosters. So that's an option available on a day in and day out basis, Monday through Friday.
Okay, and then on the testing, let's just say theoretically that we did have the staffing to staff a testing clinic. Do we have the tests available to do so? And, is there a lab nearby that has the capacity to test those?
We do. So as I mentioned, we're working on securing the instruments. The tests themselves are readily available, and we have secured the ability to get those. And then we work most directly with K-Health Labs here locally in Topeka. So yes, we have that. Again, it comes to just the staffing issue that we're up against.
Okay, and the staffing for those, it seems like administering a test is something that could be done by just really anybody who, gets an hour's worth of training. I mean, my 10-year-old can do the one at home. So is that something where, are we requiring nurses to do that? Or can we just maybe hire some folks on a temporary basis from like a temp agency?
Yeah, I think we've previously been trying to hire nurses because for vaccines, even though I mentioned we have them readily available, we oftentimes get requests for the vaccine clinics to go out. And so for me to pull nurses from my 10th Street clinic is kind of robbing Peter to pay Paul to be able to do that. So previously, we've been really going for the nurses. But I think looking ahead, now having these instruments secured as of late last week, we will be looking at, yes, not having to have nurses to do those testing pieces. The other issue we'll be working with is trying to secure a location. So we've been working with emergency management, trying to determine if we can find a location. We're actually looking at site boxes, which is what the public is used to seeing at both Walmart and Hummer Sports Park, so that we would be able to open up shop. We realize testing is an issue here in our community, and we are actively trying to help ease the burden.
Okay. Dusty, so during Country Stampede, I had gone out there and there were a number of trailers that were brought in for that event from emergency management, not just here, but from surrounding areas to be used as kind of a home base for the security and things. Is that something that we might be able to obtain to do a mobile testing clinic somewhere?
If they're not already being used somewhere else. We do have some of the regional equipment that's already staged here in Shawnee County being used currently. So it's not impossible to do that by any means. It's just availability, just like all the rest of the resources we're having the same problems with.
Okay, thank you. Commissioner Upon.
I have a question about kids and sports. The NCAA released an updated COVID guidance on last Thursday for winter sports that recognize athletes with natural immunity from previous coronavirus infections as being equivalent to being fully vaccinated. The new guideline also defines fully vaccinated as having taken both primary doses of COVID vaccine as well as a third booster shot. I think this is worded poorly. I don't think there's a third booster shot, but what's your thoughts on that as far as kids and sports? Do you feel like if they've had coronavirus, they're good to go, can play, or?
Yeah, so we're talking, I think, about the isolation and quarantine guidelines here. Previously, we allowed for, once you had an infection, you could have 6 months quarantine-free. And so that was how we were operating. So, for example, a child on the basketball team, even if they were exposed, they would be able to continue playing basketball. With Omicron, that has changed. It has been shortened down to 3 months. So a child on a basketball team, as long as they've had an infection in the past 3 months, would still be able to continue to play.
Okay. I want to go back to the monoclonal antibodies. Is anybody raising Cain with the Biden administration to get this, I don't know if you call it at least a treatment. Is anybody pressuring them to get this stuff? Is anybody pushing?
Well, I will
Are
admit
they waiting
that
for me? What's the protocol? How do we get that thing going? How do we get it rolling?
I think that the federal administration is under considerable pressure from essentially every direction to
Are
get
we
this.
applying pressure?
I admit I am not directly applying pressure on the administration.
Are the hospitals?
I was just going to say on the KDHE calls, I think that there is requests from the hospitals. You know, I mean, I think that the medical community is asking. You know, I think the Omicron variant, I think it kind of surprised everyone, but I mean, you know, there's no direct pressure for me, but we are working through the channels.
And we're not getting it. We got 12 doses of this. I'm sure there's a lot more than that out there. I'm sure. Even if you took all the states, went by population, there's more than that out there.
I think
Setting on it.
one way that they're allocating is really looking at the need from state to state. And so there are states that are in worse shape than us, so they get prioritized a little bit more. And so it's not an easy decision, obviously. Allocation is never perfect, but that is what they are doing from a federal standpoint. Instead of requiring us to compete against each other, like we're demanding this much sotrovimab from GlaxoSmithKline, instead, the company is manufacturing it as a whole and giving it to the federal government and then distributing more equitably.
Okay.
Dr. Locke, on the sotrovimab, you had mentioned earlier that that's the only one that's effective against Omicron. And so I guess, are the others readily available? Is it just that one that's in such scarce demand, or?
Yeah, well, that's also a very good question. They were, it's all a bit relative, I would say. Previously, we also had one called Regencov, and we had another called Bam-Edi. They were more readily available than the sotrovimab, but they themselves have been on allocation with the Delta variant as it was sweeping across the country. The same process was occurring, but we were getting more doses of that at the time with a lower need. So from a ratio perspective, we were in a better position.
Are we still getting any of that locally?
My understanding is that fairly recently, we had been receiving that because the threshold was if you were less than 80% Omicron, then that meant there was still a lot of Delta. There was a bit of a chance. Whether you had Omicron or Delta, we wouldn't know, but we would still give you the antibody. Once you cross that threshold of 80% Omicron, essentially every person, more or less, who is in need of that therapeutic would really need the sotrovimab. And so it is no longer, it would be a medicine that was not helping and might only cause harm. And so at that point, they've been retired and it's just sotrovimab.
So I guess my question was not so much if we could use it currently, but is there a benefit to getting it and stockpiling it for the next variant? Is there an expiration on this stuff? Can we take it and put it in a freezer and keep it for 6 months just in case?
Perhaps that's a question for the hospitals. Certainly everything has an expiration date, and not being involved in the day-to-day of that, I don't know for sure exactly how that would be handled, but it is certainly an interesting idea because the next variant may well be able to be used against that. Dr. Hyland or Dr. Dishman, any news on that?
I think we had difficulty keeping up with the administration of Regeneron with the Delta surge. And then I think, as soon as we get the monoclonal antibodies, we will administer
I
them.
think to stockpile because the virus can mutate. I'm not sure that is the best direction to go in. But what can decrease the likelihood that the virus will mutate is to get vaccinated.
I agree, Jackie. I think it would be relatively impossible at this point to predict what the change proteins are going to be in the spike to allow us to predict what monoclonal antibody we're going to need. And again, just as Dr. Hyland mentioned, as soon as we get them, we're administering them.
So noticeably quiet has been Commissioner Cook. Did you have any questions?
No, I think from the hospital, it's really clear that at this point they are asking the community to masks, and they are asking the community to get vaccinated if and when possible. And so I think the messaging from the hospitals is very clear to the public and to the commissioners. So I don't have any questions for them. I think the next step would be asking Dr. Locke what her recommendations are for us as a Board of Health to consider.
I'm done.
Nor do I. We've been here for quite a while. I'm going to go ahead and say that we recess for 5 minutes to give everyone a chance to stretch their legs or go to the restroom or whatever needs to happen. So we will, let's just say maybe a little bit more than 5 minutes. Let's reconvene at 11:40.
Thank you, Commissioner.
Whoa.
Yeah.
That's a lot.
You need to step up.
Yeah. All right. The time is 1:40. We will reconvene. I'm sorry, what? 11:40. Sorry. Thank you for the clarification there. The next item on our agenda is a legal update from Jim Crowell, Shawnee County Counselor.
Good morning, Commissioners. Jim Crowell, Shawnee County Counselor. I'll try to be thorough on this subject, but brief, if that's possible. At the same time,
I'll hold you to that.
I want to discuss the process for issuing health orders, and let me clarify what that means, what type of health orders I'm talking about. You've heard some discussion this morning about isolation and quarantine orders. Legally, I characterize those as specific orders. Those are the type of orders that are going to apply to a specific person for either having a positive test and needing to isolate, or for individuals that are exposed to that positive person who need to quarantine. I'm not talking about those orders. Those are set in a separate set of statutes that have been in place since 2005. And so far, during this pandemic, the legislature has not amended or changed those. Those orders are issued by the local health officer, and there are circumstances where the Secretary of the Kansas Department of Health and Environment can issue those orders. We're not talking about those. What I'm going to talk about today, very briefly, is the current process for issuing general health orders. And what I mean are orders to the general public, a mask requirement, gathering limits, business restrictions. We're all familiar with capacity limitations, closing requirements. I'm talking about those types of orders today. Now, to put the current process in place, let's go back to the way it was when we started. When we started, there were really three individuals under state law, state statute, that could issue general orders: the local health officer, the Secretary of Health and Environment, and the governor through the Kansas Emergency Management Act. And if you will recall, fairly quickly on in March of 2020, the governor did start issuing mass general health orders in the state of Kansas. In response to that, the Kansas legislature enacted legislation that went into effect in June of 2020 that really changed the dynamic completely for us. I know that you three are familiar with it because you were thrust right in the middle of it, and that is they changed it to where if the health officer had issued an order, local health officer, or if the governor had issued an order, it gave the Board of County Commissioners the opportunity to supersede those orders, either through an amendment or to eliminate those orders completely. That was the process that remained in place until SB 40 was enacted by the legislature last spring, and that's what I want to talk about a little bit more today. Let's see if I can, I can't find the, can I minimize this and then get to this? So I'm pulling up really the meat of what the legislature did. This is from KSA 65201, and Senate Bill 40 was a set of amendments and new requirements that the Kansas legislature enacted that dealt with the Kansas Emergency Management Act, so the authorities and powers of the governor. Also dealt with orders issued by school districts, other local governments, and these are the sections that deal with county governments. And this is found in 201. So now, under SB 40, if the local health officer determines it's necessary to issue an order, and it's an order that falls within one of these categories, mandating the wearing of face masks, limiting size of gatherings of individuals, curtailing the operation of business, controlling the movement of population of the county, or limiting religious gatherings. Now the health officer cannot simply issue the order. The health officer must propose the order or recommend the order. Then at the next regularly scheduled meeting, such as today, the Board of County Commissioners can consider whether to enter the proposed order or to modify it or do what's in, take whatever action they deem necessary. Another new provision that comes out of SB 40 is the appeal language, which is highlighted in D1 below. This was new as of last spring, and it allows any party aggrieved by such an order to file an action in district court within 30 days of the order being issued. If an appeal, such action or appeal is filed, then the court is required to conduct a hearing within 72 hours and must act and render a decision on that appeal or petition within 7 days. And the statute sets up basically a default procedure. So if the court did not act within that 7 days, then it's presumed that the relief sought is granted. And one important thing about the relief sought language, that's what you're asking for when you file a lawsuit. This statute does not simply limit that to a dissolution of the order. It just is broad, and so it leaves it open for the petitioner to ask for relief and the type of relief that they want. As we stand here today, I'm not sure what the damages would be. It would have to be non-economic damages if you're claiming damages from a mask order. I can understand arguments related to damages for closing a business or curtailing a business's capacity. Those types of situations, economic damages would seem fairly easy to argue for under that circumstance. But anyway, the relief sought is wide open on that. We just received some clarity from the Kansas Supreme Court. On the bottom, I've listed out the case name Butler versus Shawnee Mission School District and given you the current site that we have on that. Last Friday, the Kansas Supreme Court issued its decision in that case. That was an appeal through the SB 40 language from the Shawnee Mission School District on a mask mandate that had been entered by the school district. Now, the district court in Johnson County heard that appeal and found, number one, that because the order that was being appealed had been issued more than 30 days prior than the appeal in that case, then the case should be dismissed because it was out of time, untimely. It simply was appealing an order that had been in effect for more than 30 days. The court, though, on its own, decided to raise constitutional issues regarding SB 40 and address potential constitutional problems with that statute. Rendered a decision that SB 40 was unconstitutional as a whole. It threw the entire state into disarray legally as to whether SB 40 applied or not, whether that case should apply statewide or not, and hence our state Supreme Court got involved, issued a stay on that decision, and now has basically ruled that had the district court simply dismissed the case for being untimely, that's where the district court should have stopped. The Kansas Supreme Court did not like the fact that the Johnson County District Court on its own raise the constitutional issues when there was another basis for dealing with a case. So they announced what they call a doctrine of judicial distraint called constitutional avoidance, and it is that courts should try to avoid constitutional issues when possible, when there's other grounds for dealing with a case. So on balance, the process now for issuing general health orders is that the health officer proposes or recommends the order, and then it is up to the Board of County Commissioners, some say Board of Health, it's the same difference, must approve that order positively in order for the order to go into effect. And I'll stand for any questions.
Okay. Any questions for Jim? Commissioner Cook, any questions for Jim?
No, at this time, no, thank you.
Okay. Thank you, Mr. Counselor. Next item would be Dr. Locke again.
Okay. Now, is this on Zoom, as I'm supposed to make it?
It's still on.
It is still,
Yeah,
it's still
it's just
working
in the
okay?
background there.
Is it shared?
I believe so.
Okay.
Commissioner Cook, can you see the screen?
Commissioner Cook, can you see Dr. Locke's screen?
No, I cannot.
No, I cannot.
Okay. So now let me try this. Commissioner Cook, can you see that now?
I can see that now.
I can see that now, thank you.
Okay.
Great. Thank you, Mark.
And let's minimize. Well, it's a touchy mouse here. Here we go. Okay. Dr. Erin Locke, Shawnee County Health Officer, here to present, oh, actually, I'm so sorry. This is the update as opposed to the recommendations. Let's try this again. Actually, let's see if we can try this. It's the update. I promise the recommendations are coming. If I just know how to handle this again. Sorry. Derek, you got it? It's, the only problem is that's not it. Okay, so I think it's, okay, thank you. Derek is always helpful. Dr. Erin Locke, Shawnee County Health Officer, here to present my recommendations for the Board of Health. So just to kind of put this into context, throughout the pandemic, the health officer, both myself and my predecessor, have provided guidance and recommendations for the duration of the pandemic. And this has been done in coordination with the health department and also the incident command team. I have provided recommendations to the Board of Health, to the general public, to various businesses and schools, churches, healthcare. The list really goes on, and to various members and aspects of our community. And we've done this in various ways as well. Lots of meetings, lots of letters and communications and media releases, and using our health department website. So this is really consistent with all of the work that we have been doing since this pandemic began. And really, we have never stopped. This has been an ongoing effort by myself and my team. The following recommendations that I will be making to you today will be released on our website as updated guidance later today. I think just to reflect on where we are right now, we've done a lot of talking today. I believe that we are really in a critical moment in this pandemic. We are very tired. The community is tired. Our healthcare workers are tired. I'm tired. I think we all would really like for this pandemic to go away. What we are finding, though, is that this virus is not yet tired of us. And so we have found ourselves with pandemic high, all-time high new cases. Our testing capacity is limited. Our outpatient treatments are limited. And our hospitals are full. And we, as I have said before, are all at risk because of that. Whether we are abiding by the COVID guidelines to the T and fully vaccinated, and we are doing everything we possibly could do for this pandemic, or we are at the other extreme. Because our hospitals have such little capacity, I may have a car accident on the way home and would struggle to get a bed in our hospitals. So I realize even the health officer who is trying very hard to do this pandemic correctly, I am at risk right now. So the public and businesses and others may wonder what they can do at this critical moment in Shawnee County right now. And so we have talked repeatedly about prevention. We have talked about not getting infected. And we have already talked quite a lot about masks and vaccinations. And of course, that will be a part of this guidance. But there are other actions that can be taken too. And so I'd like to start with my recommendations for the general public. So I think this is something that we've all grown up with and is not new advice. But my ask for the general public is that if you are feeling sick, please, please stay home. Do not go to work, do not go to school, do not hang out with your friends or go out to eat in a restaurant. If you are feeling sick, given how high COVID-19 is in our community, it is extremely likely that you have COVID and you would be passing that on to other individuals. So one of the best things that you can do is that if you are feeling sick with symptoms, stay home. It's a very simple message, and I hope that resonates with our community members. My second request is to test frequently. Now, I completely realize that is a request that sometimes, to your best efforts, can still not be done. We are doing 7,000 tests in a week, and there are still more people who need to be tested than what we are able to supply. Those individuals who are most in need of testing are those who are actively feeling sick or they know that they have been exposed to COVID-19. It is really best for you to complete your isolation or to test to make sure that you're not actively infectious before you are going out into the community. My third ask is to wear your mask, and we've been saying this quite a lot today. That mask needs to be well-fitting, and as Omicron has arrived, we are recommending an upgrade to a KN95. An alternate to that is a medical procedure mask, and I'll tell you, I wore my KN95 in today, and I switched to this because I thought you'd be able to hear me better. But I myself have switched to a KN95. These masks are available online or in stores, and so we don't have the shortage of these masks that we did a couple years ago. The health department has also put in an order, a large order of these masks to be used within our facility and to be distributed to the community as needed, and we plan to place another order. My next request for the general public is to avoid crowds. At this point, as I said before, 1 out of every 5 people who are going to get tested are coming back positive. You can imagine that in any crowd, such as what we have here today, there is a very high chance that someone is going to be positive. The bigger the crowd, the higher your chances. With that, I encourage our general public to reschedule gatherings with others outside your household. Reschedule them for potentially a month from now, 6 weeks from now. We don't think that the trajectory of this is going to be as drawn out as what it perhaps has been with other waves in the past. To be honest, we really don't know. But to start with, consider rescheduling because there's a very high chance you will become infected if you proceed. We've already mentioned getting your vaccine. Of all the shortages that we are experiencing, the vaccine is not a shortage, and it is the most effective thing you can do to prevent yourself from being infected, from getting put into the hospital, and from dying. And so if we're talking about our shortages and we're talking about what we can do, it is almost a miracle that we actually have this vaccine, and we have plenty of it. And so please, if you have not been vaccinated, consider getting your vaccine now. If you are outside of that protection window that I was speaking on before, please get your booster. And then my next request, and Commissioner Rippon, you had set this up very nicely, that there are individuals out there who would prefer to not follow the isolation and quarantine guidance. This guidance is really set up to protect our community and to protect our neighbors and our family members and our friends and to get our life back to normal. It is not meant to be like an intense restriction on our personal liberty. It is about our community and trying to get us to a better place. And so my request is that you please follow the isolation and quarantine guidance as it applies to you. I did put a quick 3 links there for testing where I recommend people start: the knowbeforeyougokansas.com, the vaccination, which is the vaccines.gov. And for questions of isolation and quarantine, I put the health department website on there. There's a banner, there's additional information about it. And of course, our hotline and emails are available for any questions along that for isolation and quarantine. My next recommendation is for businesses. As I've already touched on previously, businesses are going to struggle and have their own challenges during this time. Employees will be getting sick. They may not feel safe at work. Our community members may not feel safe going into those businesses. And so I anticipate that this will be a difficult time for our businesses as well. My recommendation is to pull out your infection control policies and really, to reaffirm them, strengthen them as you need. I recommend that if an employee is sick, that you very quickly send them home so that they don't make the rest of your employees all sick as well. I recommend that you utilize the sick time to support that decision. I recommend that businesses require masks of their employees as well as their patrons. This is for both the benefit of keeping your business open, but also for the safety of the patrons who attend and as I mentioned before, be more likely to patronize your business. And then the other basics that we frequently talk about with ensuring distancing, with increasing your cleaning, particularly those high-touch areas, as well as optimizing ventilation. It's a hard time to open windows or doors right now, and I get that. But we have HVAC systems, and we can use those to their benefit. We need to make sure that they are maintained and that they are optimally working to improve that clean air that's coming into your business. And OSHA has a whole website dedicated to this for just regular businesses to take a look at how they can keep their employees safe. In that same vein, much as we did before, allowing employees to work remotely is a very good option right now. A short-term option, I don't think that it's going to be, months and months, but to get us through this wave, this would be a very good option, when possible, to allow your employees to work remote. I recommend pulling out your continuity of operation plans and whatever policies or procedures businesses have in place to prepare for staffing shortages, as well as to prepare for supply chain shortages. It may need that, and this may go on for longer than just our wave here in the community, but it may be alternate sites of supplies or non-traditional sources of supplies may be needed for our businesses. And of course, we have a wide range of businesses, so that will vary from business to business. In addition, a very important piece, and this is what I was mentioning before, is that the safety practices that you have in place, communicating those to the public and to your employees is a very sort of a best practice in all of this. The safer people feel, the more likely they will be to want to get to work. The safer you make it, the more likely they will be to be able to stay at work, and the public will come to your business. So those are my recommendations there. For our events and other mass gatherings, my recommendation for the next 4 to 6 weeks at this point is to please reschedule, or if you still need to have it occur now, to move it to a virtual setting. If the event must occur in person, as I've mentioned before, any sort of crowd is likely to have infection, is likely to lead to a super spreading event. So my recommendation is to decrease your attendees to half the room occupancy so that you can enforce physical distancing between different households. I recommend that you require masks at your event. And again, as I mentioned previously, you optimize the ventilation within that setting. My recommendation as the local health officer to the Board of Health is that we institute a public health order for a mask mandate for 1 month in duration. This would be a community mitigation strategy which would help to slow the extremely rapid spread of Omicron in our community. The purpose would be to ensure that our healthcare resources have adequate capacity for all of our community members who require medical care, be it COVID patients or non-COVID patients. Our second purpose would be to minimize the economic and social disruptions that I've just been discussing in my previous slides. A mask mandate has been shown to be an effective strategy for communities. There is copious research that supports this as a community mitigation strategy. It also is the least restrictive. It does not shut down businesses. It does not restrict crowd size. It does not hinder the economy. In fact, the purpose is to encourage the our ongoing economy and our society. And that is all I have as my recommendations today. Any questions?
I have a question. In your recommendations, do you have any for helping people boost their immunity or their health? I mean, would taking vitamins be a good recommendation? I've heard vitamin D, zinc, different things like that. Are there any recommendations like that, or is it all just physical stuff?
The purpose of my recommendations is more from a public health perspective with those recommendations. However, if an individual is looking for that sort of advice or recommendations, to discuss that with their medical provider would be what I personally would recommend. From a public health standpoint, we certainly know that the healthier individuals are at their baseline, if they are of healthy weight, if they are exercising, if they are avoiding things like cigarettes or smoking, or alcohol. We know that those sorts of factors from a public standpoint can improve the overall health. But on an individual standpoint, my recommendation would be to speak to your primary care provider about that.
I see last week CDC came out with a statement said that cloth masks don't work. Would your mandate require a higher quality of masks than cloth?
Well, I think to answer the first part of it, there is concern that the cloth masks are not as effective with Omicron as previous variants. They have not said that they do not work, but that there is some concern that we may need to upgrade to be at our most effective. Given, however, that not everyone has access to be able to purchase the really high-grade masks, the order would not require a surgical mask or a KN95.
I had one other question about, and maybe this is a Jim question. it has enforcement on here. And the fine is $2,500 per violation. I don't think I'd get charged that much for driving 60 through a school zone.
That's just language from the statute. It's up to. I don't think any prosecuting attorney would seek that on a first violation.
That's just what the statute
That's
limit
what the
is.
statute, that's how it's written, to allow fines up to cover every possible scenario.
Okay.
Mr. Chairman,
Yes, Mr. Cook, go ahead.
Dr. Locke, I just want to clarify your order. You are asking for it to be 1 month in duration,
That's correct.
and you are not asking any businesses to close or suspend their
The county or
operations.
district.
That is correct.
The recommendations there are primarily as to the public, the mask, and that for any mass gathering, you would reduce it to 50%.
Those are my, yes, those are my recommendations that people could choose. It would, the order itself would be strictly about masks.
Okay.
I have a couple of
I
things.
might- Oh, go ahead, Commissioner Mays.
Sorry, I've got a couple things here. Short of a mask mandate, I think there are some things that we could do to help. Obviously, county government is not going to change the world here, but we can do what we can for our citizens. And I do think that we need to buy some KN95 masks to distribute throughout the community. I know we can get them relatively inexpensively. The general public, if they're buying them online, are pretty expensive if you're buying just 4 or 5 of them at a time. So I think that's a start. I think we need to find a way to increase our testing capacity, and whether that's buying a pallet of home tests and distributing those throughout the community, or finding a way to set up a clinic, I think that's a good start as well. We've got 2 mass clinics in Shawnee County. It'd be good if we had 3 or 4. That way it's more convenient for folks. I know for me, to drive to the Walmart on California or to Hummer Sports Park from my place is pretty far. Not everybody has reliable transportation. That'd be good to have that out there as well. Also, I'd like to probably add the nurse navigation line. I think it'd be good, maybe we put that on Thursday's agenda to talk about and see if we can fund that with ARPA funds for a couple of years at least. I think that would help maybe ease the burden for AMR. And then I think that, Dusty had mentioned we have to request the National Guard in order for them to activate. Maybe that's something we need to consider as well, is putting in a request to the National Guard, maybe for medical transport in some situations, maybe for non-medical positions in the hospitals, to do some of the things other than patient care that needs to get done, because I know the staffing shortage is bigger than just nurses and doctors, and maybe to even help with testing capacity as well. So Dusty, you look like you wanted to say something on that.
Just in general, there are some restrictions, and we can request the mission. We have to be pretty specific, and again, no guarantees because everybody's doing the same thing. But yes, you're absolutely.
Well, I know that I don't have the power to unilaterally ask for that, so maybe the other commissioners might want to weigh in on that.
I think that'd be a good idea. I don't know how that works. I just don't know. But
Yeah.
Basically, the short version is we have to exhaust all resources, which I think is pretty clear that we're at that point. We have the declaration in place, and we have to write it up as a mission, not necessarily saying this is exactly what we want. We need a testing branch or whatever the need is, but we do have to show that we've exhausted all local resources, and sometimes even regional partners and mutual aid partners. So we can explore it. I don't have a good settling that it will happen, but we can try.
Dusty, if we make a request, who makes the decision whether to grant our request? Where does that come from? Does that come from the governor's office or?
Depending on the request, they have to source it just like they would anything else. So if I did a request for a trailer, something like that, we talked about that. If something meets those specs that would meet that mission, ADA requirements, all the things that we would need, we can get that trailer on site. Doesn't necessarily come with staffing. That's the other catch. And sometimes it comes with more. If in the past we've requested generators. We got the generator, but it also comes with 2 guardsmen to run that generator, monitor that generator. We have to pay that too. So there are some things we have to explore on this, and it's not out of our own possibility, but we have to explore a little bit.
Could we go ahead and look into that,
Yes,
though?
absolutely.
Thank you very much. Commissioner Cook, did you have anything to add?
Well, Commissioner Mays, I appreciate all of your recommendations. I don't have any issues with them. I do think that we should consider the adoption of the health officer's recommendations,
including the mask mandate. Back in March, Commissioner Rippon, you said our numbers are dropping like a rock, so we should drop the mask requirement. We're at a point now where our numbers are higher than they've ever been. So I think that Commissioner Mays, you and I both agreed that when numbers are good, we loosen restrictions. When numbers are bad, we add more restrictions. So I think that the health officer's recommendations are reasonable and should be adopted.
I don't know that you and I ever came to any kind of formal agreement on anything. I also recall a conversation, I believe in March of last year, when we had discussed lifting the mandate, and we'll do a little history here. When the legislature modified the chemo law originally, as they were hurriedly leaving session in 2020, the message that they sent was that they no longer wanted the governor making those decisions, and they wanted the county governments to make those decisions instead. Fast forward to the next legislative session, Senate Bill 40, I think the legislature made it abundantly clear that they were not happy with the way that we conducted business, and they wanted to take that power back from us. The fact that anyone could sue us for any health order that we implement right now for basically any amount that they want certainly makes this a challenge, because, you know, we've only got, how many people are in your office, Jim?
4 attorneys.
4 attorneys in Jim's office who are already very busy with a number of other things. Do we want to add additional caseload to them and put ourselves in a vulnerable position to any kind of lawsuits that may come? Now, I know an argument could be made that there's another county that does have a mask mandate in effect. You know, how come they're not being sued? Well, the ruling from the Supreme Court just came, was it Friday? Thursday or Friday of last week. It's very, very new. I would imagine they're probably going to get sued before too long, and then maybe we'll have case law to back it up, but right now we don't. And the uncertainty right now, I don't want to put us in a position where we're putting the taxpayer dollars that we receive in jeopardy for something that, you know, yes, masks probably do help. They do help. But I don't know that mandates do. I think that there's a segment of our population that's currently unvaccinated, and they're unvaccinated because of, for reasons that they hold close to them. I think the folks that are vaccinated right now are probably better protected, and many of them are wearing masks currently. But I think those folks that have chosen to not get vaccinated at this point are probably also not going to wear masks, whether we mandate it or not. I'm not convinced that masks are the answer to our problem, which is why I've proposed a number of other things that might help. At least I hope they do. So this time, I don't think I could support a mask mandate.
I too have suggested things that I think we can do. you know, it seems like the critical issue right now is the shortage in the hospitals. And I don't know that a mask mandate's gonna help that. I think, you know, people can use their own discretion on wearing a mask or what type of mask they wear.
Well, oh, sorry, I don't want to interrupt.
Oh, that's all right. So I don't think I can support either. I don't want to put us in a liability issue as well.
I will say.
Commissioner Mays,
yes.
if we could have the county councilor respond to your concerns about.
And the ability of his office to defend any lawsuit.
Issues related to the pandemic, and we will continue to do so to the best of our ability. I don't know what else to say beyond that.
County councilor, do you believe that there would be lawsuits
that would
against the
result
county
in
that would
damages from just a mask requirement, where there's no business requirement?
I think it's, personally, in my opinion, it's going to be more difficult to establish actual damages from a mask mandate than for, let's say, a rule that said you have to close your business at a certain time. I just think logically that's easier to differentiate. But people are very creative. People can ask for whatever they want in lawsuits, and we'll still have to put resources towards defending that. So that's the best answer I can make. We will do our level best, no matter what this board decides, to defend the county regardless.
Okay, with regards to Senate Bill 40, that bill I felt was specifically directed at school boards and counties. Cities have constitutional home rule, so it doesn't really apply to them. And if people don't like Senate Bill 40, I would recommend calling your legislature and legislators and asking them to change it. At this point, it's the rule, it's the law of the land. So I feel like, you know, it was designed to prevent us from putting these types of things into effect. And I think that with the legislature coming back today, the possibility of us having even more punitive bills passed related to counties is out there. I think it's a high probability that there's going to be more restrictive legislation passed for us.
I believe that's true. I'm not opposed to your recommendations, but I just want to keep it at that level, recommendations. The order is just, I don't know. I still think there might be some liability issues, and I think a lot of people can use their own discretion on this.
I would make my recommendation that citizens of Shawnee County do what you can to not get COVID. I mean, that's, you know, all of those things you said work. Staying home, not going into large groups, wearing a mask when you feel you need it, get vaccinated, all of those things. I mean, that's the request. Dusty?
Kind of hear the way this is going. I'm going to take the opportunity, business-wise, as far as continuity operations, within the EOC downstairs, and I would encourage other department heads to do the same. The mask will be a requirement for emergency managers in uniform. We are going to shut down the EOC with face-to-face meetings. We're going to probably go to virtual everything as possible. Keep my guys safe as possible, because we can't get sick, same as anybody else. Our shortages can't reach the level that the hospitals are. So I just want to make that public notice that we have that right now.
Sure.
Just do that right now.
I appreciate that. We have made it, we've made directions to our department heads that they have the ability to do that within their departments if they feel that it's necessary. I know corrections also has kind of a mask mandate in the jail. I mean, there's a number of places where it's appropriate. I understand emergency management, you want to keep everybody as healthy as possible, so thank you. Any other comments? Seeing none, we are adjourned.